We are going to finish bone today and start muscle, but muscle is not on the first test, on the second test. So you don't have to stress about it. You can just like absorb whatever you absorb today, and later on we'll get the rest. Your first test is Tuesday. Yeah? What does it cover? Histology. Yeah, all the anatomical terminology, body regions, basic stuff, right, that you use to start. And then skeletal system, including lab material, right? Any lab material that is reasonable to ask on a 2D picture is fair game. Good? Yeah. Mm-hmm. Yeah. You're done with it this week, right? What the hell you want, right? You want me to wait in 6 weeks to test you on it? No.
I want you to hold my hand, Melanie.
All right, that's fine. It's going to make it really hard for you to write, but yeah, poor Charlie. Charlie's like, shut up. You dissing me? Was that a joke at my expense? No, I'm just kidding. Okay, so let me show you a couple things that I thought you would think were cool. I told you I had a student who drew, right? Charlie, do this. Draw all over your damn arms. You should, right? I don't. Right? Yeah, paint it. Oh, that's a great idea.
Right?
You should. Would you do that? I want to see it.
Yes, I will.
I know you've got a whole bunch of extra time. You don't have anything to do. So will you please do that just for my entertainment? So I think that's really cool. And then I thought you guys might like to see a dry bone so you can really see the difference between spongy and compact bone when the bone is all nice and dried and sectioned like that. I was going to show you all of this last time, but then you guys decided to break the electricity. So, and then you want to see a super duper gruesome scoliosis?
Yes.
Okay.
That's so rough.
Yeah. That is not minor scoliosis. That is life-changing scoliosis that you can see. This is a pathological anatomy that you can see. This is a less gruesome one, but still pretty damn dramatic scoliosis. Okay, so what we are going to do right now is talk about fractures and how you heal them, right? Then we'll talk about joints and arthritis, and then we will move on to muscles. Cool? Okay, so fractures and the healing of fractures is actually relatively easy after you have learned ossification, because what it really is kind of a little mini endochondral ossification. So if you fracture a bone, I'll show you this picture. This is where are you? My darling husband. This is his X-ray. See anything wrong with that picture right there, right? We could see Charlie's X-ray. Oh, wait, let me see it. What did you break?
That's before, just a radius.
Ooh. How'd you do that?
Snowboarding.
Oh, yeah. I was going to tell you about snowboarding today. It's a really good way to break things. Would you like to know how my husband does not like me to tell this story, which means it's entertaining?
Oh, yeah, for sure.
Yes. My husband broke his clavicle because he's a musician, and he went to Burning Man once without me. Not recommended. And apparently there was whiskey, a tricycle, he's 6'6", and a ramp, and a 44-year-old man involved, and that is what happened, right? He tells me that that's not a good story. I'm like, that's a fantastic story. I love it so very much. And it was the first day of Burning Man, so he stayed the rest of the time with a broken clavicle. Yeah. He had 4 gigs that he was playing at Burning Man, so he had to stay, right? And he played all of his music with that. So how do you repair this damn thing? Let's talk about that. So let's break a bone and figure out what happens. So what happens when you break a bone is, first thing, before you start the whole ossification process, is you need to clot, right? Because remember that bone is very vascular, right? So you form what's called a fracture hematoma, which is basically just a blood clot that actually clots the vessels that were broken, okay? Clotting is not usually problematic in bones in a healthy person because A, clotting is initiated by platelets, which are made by the red bone marrow, and B, it is really dependent on calcium, which is abundant in this location. So if you are otherwise healthy, this is probably not going to bleed out, right? So you have this hematoma formation, and then what you're going to do is you are actually going to start building what is a callus They call it a callus of cartilage, but we need it to be really strong cartilage. So instead of just replacing that with hyaline cartilage, I'm going to make extra strong cartilage, which is what kind? Fibrocartilage, right? Which is really just hyaline cartilage plus extra collagen, right? So I want this to be really, really strong. The way that you do that is there are always a few mesenchymal cells left behind, even though you don't have any tissue. You migrate those into the tissue and you start to differentiate into first chondroblasts. Then the chondroblasts make cartilage matrix, right? When they're completely surrounded, they are chondrocytes, right? And then you have this lumpy fibrocartilage callus, which if you felt the edge of the bone, you would actually be able to feel it on the outside of the bone. So this fibrocartilage callus will protrude. And the time it takes for this to occur really depends on where this is, okay? So when my husband broke his clavicle, you can't cast that, right? So if you can't cast something, the healing tends to be slowed because you can't immobilize it. And so you're going to put stress on it, right? Right? So because this, right, if this were, for instance, my humerus that was broken, once the fibrocartilage callus is there, if I try to move the humerus, is that part going to be stable, that fibrocartilage callus? No, it's going to bend right there, right? So if you can immobilize it, you can actually speed healing by reducing the amount of stress that's put on that point. But you can't immobilize everything. Because if you break your toe, they say you broke your damn toe. That's going to hurt for a while. What happens if you break your tailbone? That's broken, right? Yeah? So you can't cast everything. You can't immobilize everything. But when you can and you feed yourself well and immobilize it, it'll heal a little faster. So that's usually 3 to 4 weeks, really depending. And then what you're going to start doing after that is you need to keep it immobile. So if it's casted, it still needs to be casted. And it needs to be casted all the way through step 3. And step 3 is when you form a spongy bone callus in the middle. You form a hard or spongy bone. And what you do there is basically just a little mini endochondral ossification. You migrate osteoblasts, osteoclasts, progenitor cells into the cartilage, right? Okay. And then you start to make bone, and you make the easiest bone first, which is what? Spongy bone. Even though it's not gonna stay spongy, right? It's easier to make spongy than it is to make compact. And so now you have this spongy bone callus, and this is usually when they take the cast off. But not because it's strong there. Why would they take the cast off at this point? Yeah, you need to move it because remember, bone is motivated to do osteogenesis and when you actually move it, when you put mechanical stress on bone. So what you need to do at this point is you need to take the cast off, but you also need to remember that it's not baked yet. Yes? So if, for instance, you went snowboarding and broke a damn bone, and then they take the cast off, right? And then not Charlie, but if you were my 13-year-old son who went snowboarding and broke a bone, and they took it off, what would he do on a day like today when given the opportunity? He would go snowboarding again. Exactly. Don't you do it. What? Have you been snowboarding?
Well, I mean, they say the worst fractures is when you have a cast and then you fall and then it breaks at the point, you know?
So,
But they won't let me because it's already out of place, so they said it could fall out of place.
yes, but you're waiting until they take it off and then you're going to go and then you're going to break the damn thing again. Okay, so what's going to happen? And she doesn't even have testosterone as an excuse. What the hell, right? Testosterone increases risk-taking behavior. It's an evolutionary stable strategy. It's also really hard to parent through. I will tell you that shit, right? Okay. I'm like, I know you're supposed to be doing this, but I have kept you alive until the testosterone hits, and I don't know what to do now. Take it off at this point. You need to stress the bone, but you need to stress it gently, right? You need to be good to it because it is, if from here to here, it's still very likely to break in this point right here. Now, from here to here, this remodeling process occurs where you scoop out the middle with osteoclasts, right? Replace the bone marrow with mesenchymal cells, which can make bone marrow, right? And then you remodel the edges with osteoblasts and osteoclasts until it's really strong at the edges. If you let it completely heal, and this can be months down the road, it depends on which bone you're talking about and whether it's immobilized and you're feeding yourself well. If you let it completely heal, it's actually slightly stronger at that point than it was before because you end up with a net deposition of collagen fibers, right, during the healing process. But it's a little comparatively weaker right here, right? So if you stress the bone in a really similar way after it's completely healed, it's less likely to break right here, but it's a little more likely to break, right? So if you have a really strong link in a chain, then comparatively the two ones around it are relatively weaker and so more likely to break. So, but of course, although it doesn't show it on this picture, you can always tell that a break occurred on an X-ray after the fact, because what you end up with at the site of healing is a little line that looks very much like an epiphyseal plate. Yeah, epiphyseal plate, which is kind of what it was, right? It was like a little bit like that, right? There was cartilage and then it sealed and then there was no more cartilage. So it will always interrupt sort of the pattern or the structure right there, and you can always tell in an X-ray where things are broken. You can, of course, use that as a forensic identifier, right? You find skeletal remains of a human that has an obvious femur fracture that was pre-mortem, right? Didn't happen at the time of death, wasn't the cause of death. You can use that as an identifying characteristic, right? So they use those for identification. Sometimes it's also an indicator that there might be some skeletal developmental problem. Like, I don't know, anybody work on the ER here? Anybody? No? Okay. I usually have some students that work. Oh, you do? Okay. So just in theory, if you had a child that came in with a break and you x-rayed and you found 7 breaks, right? That's initially what you would think. And it's pretty likely to be the answer. There are some bone disorders that actually cause bone breakage with normal use, but they're actually relatively rare. So abuse is what you would think. So you can use this to sort of indicate. Anybody in here broken a bone and can still feel the site of breakage, right? Yeah, I broke my jaw when I was a kid, right? I jumped off a house. My mom told me I could fly, and I thought she was being literal, but she was being metaphorical. And I jumped off. I jumped off a few times, and it just didn't work, and I thought I was doing it wrong. So I just jumped off, and then one time I actually hit a branch on a bush. But I can still feel it. Got still a bump. It's left behind. You can still feel the location of break, right? And if I get killed, they're going to know right there to identify me by that. And it's my husband, by the way. I'm just going to go ahead and put it out there. Okay. It's always the husband, you know. It's the spouse. They're who's going to kill you. Okay. So you broke your shoulder? Uh-huh.
Skiing, but from a toe rope. Just like
ow!
The greater tuberosity here and for my rotator cuff, and I can still feel it.
Ooh, yeah.
Just from the toe rope at Park City Ski Resort.
How the hell did you break a bone with the toe rope?
I know. It was like a fluke accident. So weird.
It's because you're not 22 anymore either, and my husband's not. He doesn't believe it.
Yep,
He thinks only I got older, and he's still 20. Right? He's like, no, that's not for you. And I'm like, it's not for you either, you old geezer. Sit down, boomer. Neither one of us are boomers, right? We are the Gen X generation, and we're judging both generations on either side. Okay. So clinical connection now. I want to talk about bone mass loss, right? I know you guys are familiar with the term osteoporosis, but I want to tell you that not everyone will get osteoporosis, but everyone will have osteopenia to greater and lesser degrees, which is sort of the natural loss of bone mass associated with usually aging. Go ahead. Oh yeah, if you damage a joint or a bone multiple times, you are more likely to get both arthritis in that joint and bone mass loss in that location. Yes. Uh-huh. This is the third Charlie, you need a mom. Where's your mother? I'm gonna text her. Give me it. All right. I'm gonna take away your pass. Where do you have a pass? Okay. So osteopenia is the bone mass loss due to aging. And what do I mean? We all lose bone mass as we age. It usually starts in 30s. It doesn't have to. If you're really physically active, it doesn't. But so what I want to say is if I compared any person at 25 to that same person at 85, they will have lost bone mass from 25 to 85. Does that make sense? Okay. It's natural to lose it. Now, what takes it from osteopenia to osteoporosis is that osteoporosis is when you lose so much bone mass that it compromises normal functionality, right? And not all of us will get that. And we'll talk about what predisposes you to osteoporosis or not, okay? So, osteoporosis. loss of bone mass to the point that it compromises normal function. And you guys should know from talking about it before, which type of bone tissue, spongy or compact, is going to be most affected most quickly by bone mass loss. Spongy, right? It's because you can get at it. So this is a normal spongy bone with normal bone density. This is an osteoporotic, as in pores in the bone, osteoporotic, spongy bone. And how a lot of times they would initially discover that if you didn't break something is that there are bone scans that they can do that light up hot spots, and the hot spots are where you've lost bone mass, right? And a lot of times that's due to aging, but not always, and we'll talk about that. So what makes it osteoporosis? Well, there's a whole bunch of potential symptoms, but the ones you might care about are fragile, easily fractured bones, because of course, if you look at this, you've lost some structural integrity of the bone, right? By drilling little holes in it, you've lost some structural integrity. Just think about this as basically a foundation of a home with termites versus a foundation of the home without, right? One of them is far less stable. So fragile, easily fractured bones. That means, of course, if a 22-year-old falls on the ice, it's unlikely that they will break a hip. But if an 82-year-old falls on the ice, it's very likely that they will break a hip because the structural integrity of, especially your osteocoxy, you tend to lose a lot of bone mass in your osteocoxy as you age. What else is associated with osteoporosis? Loss of height. Okay. Now, we all lose a little height as we age, but when you're osteoporotic, you will lose quite a bit of it. And that is because your spongy bone will actually compress and you'll lose it, especially in the bodies of your vertebra, which are a thin layer of compact bone with a big old spongy bone portion in the middle. They'll kind of get compressed. If you add to that, of course, the weak musculature associated with that aging, right? You can have lost height and a humpbacked appearance. Now, it doesn't have to be associated with aging. Have you ever known anyone who had a chronic illness and ended up losing height associated with chronic illness, right? And so my mom died really young. She died in her 40s. And she had cancer for the 2 years before she died. And when she, before she got cancer, my mom was 5'9". When she died, she was about my height, which is a little less than 5'3". So she lost a massive amount. She had throat cancer. She had trouble with maintaining nutrients, right? Right? So you can lose massive amounts of height associated with poor nutrition, chronic illnesses, and those kinds of things. So humpbacked appearance, lost height, lost teeth. Now, it doesn't have anything to do with your teeth or gum health specifically. What it has to do with is some anatomy that you already learned. In your maxilla and your mandible, there are little cups that hold on to your teeth. What are they called? Alveoli. As you lose bone mass, you lose mass in your maxilla and mandible, and the alveoli go from being very deep and stable to very shallow. And you can lose perfectly healthy teeth associated with osteoporosis. Does that make sense? Okay. So who is most affected by loss of bone mass? Everyone as you age, with the caveat that an athlete at 40 could have denser bone mass than a couch potato at 20, right? So this is not a diagnosis or it's just a predisposition. If you are physically active, you are going to be more likely to maintain your bone mass regardless of your age. But there are certain predispositions that end up being important. Everyone tends to start to lose bone mass between the ages of 30 and 40, okay? But you don't have to. Wiggle a whole bunch and you'll get to maintain it, right? But is it way, way harder to stay healthy at 40 than it is at 20? Is it way, way harder to stay hot at 40 than it is at 20? You are hot by default at 20. You didn't realize it. In retrospect, you were like, damn, I was cute. I wish I appreciated that. So appreciate it now, okay? Do what I did not do. You are going to start to lose it. But it's more dramatic in women than it is in men because once you start using your sex hormones to build your skeleton, you need to keep your sex hormones to maintain your skeleton, okay? So what happens in women is sex hormones are all well and good, right? Until they start losing estrogen really dramatically at menopause. And usually it's over the course of months to a year when you stop secreting estrogen. When you stop secreting estrogen, or at least slow down on secreting estrogen, your estrogen is no longer there to maintain your skeletal mass, right? And you start losing bone mass really dramatically postmenopausally. Unless, of course, you treat it. There are some things we'll talk about, right? So what happens is men and women are going along just fine, and then women really start losing a lot of their bone mass postmenopausally, around 1% per year postmenopausally, right? And that averages up to after 30-ish. Men lose on average 3% per decade, and women lose on average 8% per decade. But the other thing is that they had more skeletal mass to begin with. Yes? Okay. Males tend to be larger on average than females. And in addition to larger, their skeleton is denser. And their skeleton is denser because testosterone is better at causing ossification than estrogen is. Tend to have a denser, bigger skeleton to begin with. So more to start with, actually 30% more on average, right? And it varies from person to person because there's great big women and little bitty men, but if you look at over average. But men, they don't, of course, also lose their testosterone in one fell swoop like women do, right? So men don't go through the same sort of predictable menopause type thing as women do. Men do gradually lose testosterone, but it's really gradual. And it's so gradual that you can have an 85-year-old man that can still father a child if he can find a 20-something-year-old woman to do it with him. And that seems to be, for reasons that I cannot verify, directly related to the size of his bank account. It is. I don't know. I mean, otherwise, there's a lot to choose from out there. He's 85, right? I don't know. So they still can and they still do father children all the way up until then. Okay, so what about your ancestry? Your ancestry does have a predisposition to mattering. Genetics matters. So some ancestries, ethnicities, ancestries, it's not really race, and my biologists really don't use the term race, FYI. But there's population groups, right? But now we're all mutts. We're all like interbreeding with one another. But if you look at population groups, some population groups tend to have less dense skeletal mass than other population groups. The least dense skeletal mass on average is people of Asian descent. I realize Asia is ginormous, right? There's a whole swath of Asia, right, that has relatively small people, relatively less dense skeletal mass. The other extreme is people of African descent. They tend to have the most dense skeletal mass, right? And then there's in between. And Caucasians are closer to Asian, right? But they have more dense skeletal mass. And then people from like South American, indigenous North and South American populations tend to be slightly more dense than Caucasian, but less dense than people of African descent. But of course, we're all a bunch of mutts now, right? So the best you can say is look at the density of the skeletal system in the people that were your progenitors, and then you can kind of predict what to expect. Now, the other thing that matters is that the size of your body matters. Little women versus big women, and of course men too, but men are less likely to get osteoporosis than women. If you are a big woman, and I don't mean obese, I mean a woman who could be 95 pounds versus 160 pounds or 170 pounds, right? Okay. If you're a big woman, then carrying yourself around is weight-bearing activity and tends to build up your skeletal mass. Yes? Okay. If you're a teeny tiny woman, it's less weight-bearing activity. You tend to not put as much stress on your skeletal mass, just moving yourself around in gravity, right? So big women tend to have more skeletal mass and maintain it better than tiny women. And then the other thing is now we're going to talk about fat. I'm still not talking about obesity. I'm just talking about having a little fat tissue. Fat tissue is what estrogen is made from. And if you are postmenopausal and also very, very thin, you're going to have more dramatic menopause symptoms than someone who had a little subcutaneous fat. So you need a little subcutaneous fat in order to reduce the symptoms of menopause. And then the other extreme is, what about extremely thin women? Extremely thin women, really thin, like I want really little subcutaneous fat. So a couple of different extremes. So we can have like a 16-year-old gymnast, right? Really tremendous musculoskeletal, good cardiovascular and respiratory activity, but really, really low body fat. Sometimes they will completely cease menstruating and ovulating. And that sends them into a little mini menopause and actually compromises the structural integrity of their skeletal system. Luckily, as young as they are quite often, when they stop doing that and they gain a little body fat, they will actually replace most of that, okay? But the other extreme is like someone with an eating disorder, someone with anorexia, right? Someone with anorexia nervosa who has almost no body fat to speak of, they will send themselves into a premature menopause in their 20s by having not enough body fat to maintain estrogen secretion. And it has massive impacts on your skeletal system. Massive impacts on a bunch of different places. Go ahead, Bridget.
Is that something reversible? Like if you were to go into like an early menopause in that state, like is that just how
It is potentially reversible. There's always an asterisk associated with it. A lot of times getting back to the position that you would have been if you had not encountered that is a little problematic, especially if it occurs in your growth years before your epiphyseal plate seal. You get one shot at that, right? So have you noticed that a lot of gymnasts are very tiny, right? Really short, okay? And that has to do with the lack of estrogen during their growth years, okay? So with anorexia, this is like a thing that I experienced when I first started teaching. When I first started teaching, I just graduated graduate school. I was 27. My students were really close to my age. And so I made friends with a former student. Her name is Emily. After she finished my class. And I didn't know this about Emily when she was in my class, but Emily and her siblings and her mother all suffered from anorexia nervosa, which is a really interesting nature-nurture question. So they've all had anorexia, and so she was in her 20s. I think she was 25. Her sister was in her 30s, and her mom was in her 50s. And then she had a brother who also had anorexia but didn't have osteoporosis. So dense skeleton. Emily and her sister had both been hospitalized for anorexia. They were both diagnosed with osteoporosis in their 20s and 30s. Her sister had already broken a hip by the time she was in her 30s. Her mom was in her 50s and was already in a walker from the loss of skeletal mass associated with anorexia. It was really dramatic. It was like a huge indicator with that. So it's really super dramatic. You can have a woman in her 20s with the skeletal mass of a 70-year-old with massive eating disorders that you're talking about like that. So, okay, so what's the good news? Is there any way to prevent it? Yeah, there is. First, have some good genetics. That ship has sailed. You got what you got, right? Second, exercise, right? Exercise to stress your bones. So what you need to do is you need to move yourself around in gravity. If you can put a little weight on the end of the gravity, it's even better. So walking is great for your hips, and your spine, your legs, maintaining skeletal mass. But what's good for your upper body is to do weight-bearing activity like lifting weights, doing push-ups, those kinds of things. Women tend to be averse to doing those things. They're like, oh, I'm going to accidentally get super buff. Literally nobody accidentally gets super buff. It does not happen. You're like, I worked out once and I got too hot. I had to stop. No, that is not what happened, right? And by the way, you don't want to be friends with the person who says that. You're like, I already hate you in the back of my mind. I'm just judging you. And I'm like, oh, yeah. So yes, weight-bearing activity is good for maintaining your skeletal mass. Now, swimming is a fantastic cardiovascular, respiratory, and muscular activity. It is not fantastic for maintaining your bone mass. Why is that? Because the stress on your skeleton is being taken preferentially by the water. Not all of it, but a lot of it, right? So do you think that, for instance, competitive swimmers have weak skeletals? No, they lift a lot of weights too. They do a lot of other things too. So it's fantastic exercise. Of course, you need to make sure that you're getting adequate levels of nutrition. You need to feed yourself. And then also you need to feed yourself specific things related to bone mass. You need to feed calcium, vitamin C and D, which are related to calcium absorption and cell division. And then you also need protein in your diet in order to maintain your skeletal mass. And then treatment. So what can you do if you are diagnosed with either osteoporosis or almost osteoporosis? There are lots of different things. They can give you the hormone calcitonin, which is the one that tones down blood calcium by making it deposit into your skeletal system. They don't always do that. They can also give you sodium fluoride, which is fluoride. If you're a postmenopausal woman, they may choose to do hormone replacement therapy, but that has a set of risks associated with for a certain population, so I'll just throw it out here. Postmenopausal women can choose to supplement estrogen to get over a lot of the symptoms of menopause, but it's not necessarily safe for a certain population of women, and that is women with a family history of breast or ovarian cancer. If you have a family history of breast or ovarian cancer, hormone replacement therapy can add to your risk. That's not true for everyone. It's for that population. So you need to know that information when you talk with your physician about it. And then there are other drugs, and one of my students knew some current information about this. I'll try to figure it out. There are a few drugs that tend to be cost prohibitive, especially in this country, that can reverse osteoporosis. This one is alendronate, which is Fosamax. And what it does is it reduces osteoclast activity and increases osteoblast activity, and you can sort of reverse some of the changes that occur. When it came out, it was super duper cost prohibitive. It was, I think, 3 pills per month, around $800 with insurance, right? And it's less expensive now. It's still very expensive. And apparently there's another treatment that she was telling me about, some kind of injectable treatment that you can do twice a year. Again, you are not getting that if you do not have health insurance. You are going to suffer from osteoporosis if you do not have health insurance or good health insurance, because it's multiple thousands of dollars. Go ahead.
So is that medication still true for like disease like I can't say
Ankylosing spondylitis.
Because that's what my sister has. That's
Yeah.
what my sister has.
Really? Huh. So you have Raynaud's and she has ankylosing spondylitis?
She has she has ankylosing spondylitis.
That's an autoimmune disorder.
I have another autoimmune.
Oh, yeah. So we're going to talk about autoimmune disorders in a second here. So autoimmune disorders are interesting, and they do have a genetic predisposition. You don't inherit them, but you can inherit a genetic predisposition. Go ahead.
Both of my sisters have a whole bunch of different kinds. Like one of my sisters has like 6.
Oh, my
And
heavens.
My other one was just diagnosed with this one, so I was just...
No, because ankylosing spondylitis is not actually a bone mass issue. It's an autoimmune issue that manifests that way. So it's not, as far as I know, and I don't know everything, as far as I know, this is not used as a treatment for that. Okay, so now we'll actually, interesting that you guys both mentioned autoimmune disorders, because now we'll have an opportunity to talk about them in just a second. So first, the last thing that we're going to do in this set of notes is talk about joints, and then we'll talk about arthritis, which is inflammation of the joints, okay? So first I want to introduce you, Chapter 9 is about articulations, but we do part of it with the bone, and we do part of it with the muscle. So how do you study? How do you know what to study? As always, you use your notes as a guide for what to study, right? Okay. So if I don't refer to it in the notes for this set of notes in this test, just study it later, right? Don't worry. I don't tend to have to pull things out of other portions of the chapter because there's enough to test on, right? So articulations. First, let me introduce you to sort of the concept of an articulation before we go any further. And the concept of an articulation says that an articulation is where 2 bones come together, but it doesn't have to be wiggly. Sometimes they're more about stability and sometimes they're more about mobility. And what happens, so let's look at 2 extreme joints. This joint between my 2 parietal bones right here, right, is a joint because it goes bone, bone, right? It's actually bone, ligament, bone. So that's definitely a joint, but it's not meant to be a movable joint, right? I don't want it to be movable. I don't want to get smacked on the head and have part of my brain move forward, right? Okay, so that's a really stable joint. It's not very mobile, right? The other extreme is this joint right here, which is really, really mobile, yeah? But it's not very stable. This is the most likely joint in your body to actually get dislocated. Does that make sense? So it's really a trade-off between mobility and stability, and all joints sort of fall somewhere along there. So let's talk about the sort of categories of joints. The most stable and least mobile joint would be like this guy right here. Those joints are called fibrous joints. Fibrous joints go bone, connective tissue that is not cartilage, it's usually a ligament, other bone, right? So bone, connective tissue, bone, no cartilage, okay? No nothing. So like a suture. The suture right here connecting those 2 bones has little bitty ligaments that hold it together, right? And to make it even more stable, the serrations of the suture is kind of intertwined, right? So it's really, really super stable. So a suture is a type of fibrous joint. It's actually the most stable of the fibrous joints. But this is also a fibrous joint, right? What holds your teeth in to the alveolus are little bitty ligaments, and they're not supposed to be wiggly, are they? No, they're not supposed to be wiggly. So that's a fibrous joint as well. It's called a gomphosis. And then this one's a weird fibrous joint because you haven't really studied this yet, but I'll introduce you to it. So my radius and the ulna. So they can either have this orientation in which they're parallel or this orientation in which they cross over one another. But regardless of the orientation, I need them to stay about that far apart from one another. And one of the ways that I accomplish this is by having this connective tissue called the interosseous membrane, which is like, I mean, I want to call it a tendon, but it doesn't attach to muscle. So it's like a ligament sheet or something. It's just called it's dense irregular connective tissue, right? Right? So, and it holds them. It's not very wiggly. It's a little more wiggly than the other two, but is it as wiggly as like a cartilaginous joint or anything? No, it's not, right? So it's called the interosseous membrane. These three are the stable category called fibrous joints. The next ones are the next wiggliest, but they're not super wiggly. And these are called cartilaginous joints. Okay, so I want to show you a cartilaginous. So this right here is a fibrous joint, hardly moves at all, right? But these right here, between the ribs and the sternum, have a little bit of movement to them, right? Right, but not as much as this, right? So this goes bone, cartilage, bone, right? Not bone, ligament, bone, bone, cartilage, bone. Does that make sense? Okay, so depending on what kind of cartilage is in there, they have two different types. One that's hyaline cartilage is called a synchondrosis. Okay, plural is synchondroses. And so the costal cartilages between your ribs and your sternum are a really good example of a synchondrosis. But also, even though it's weird to think about it, doesn't that kind of, by definition, make the epiphyseal plate a synchondrosis? Because it goes bone, hyaline, cartilage, bone, right? And they're actually a little bit wigglier there than they are at the other portions of the bone. So even though it's not a super wiggly joint, it's got a little big give to it. And then the symphyses, singular symphysis, you've already met one of those. Those go bone, fibrocartilage, bone. Yeah? Like the pubic symphysis. Bone, fibrocartilage, bone. Or the intervertebral discs will actually form a symphysis as well, right? That makes sense? So those are cartilaginous joints. And then the last ones are what we call the synovial joints. And the synovial joints are super wiggly, okay? So synovial joints you're going to primarily find associated with your limbs, okay? They got a decent amount of wiggle to them. And here, watch how you form one. Bone, hyaline cartilage, fluid-filled cavity, hyaline cartilage bone, right? And this fluid-filled cavity allows you to wiggle quite a bit without actually having friction against the cartilages or the bone, right? So this joint is going to be like this joint and here. Those are all synovial joints. Okay, go ahead.
Sorry, really quick question. So it's bone, hyaline cartilage, the fluid.
Fluid-filled cavity, hyaline cartilage bone. Does that make sense? Okay, so go ahead.
What is the cavity? What kind of fluid is it?
It's called synovial fluid. We're about to learn it. Synovial fluid is really viscous, thick, like motor oil, because if a fluid is viscous enough, then the two things actually don't come into contact with one another, right? So if you have an oily enough, viscous enough surface, then they don't contact one another. Kind of like when your car hydroplanes after a storm, right? Just the right viscosity of oil on the road will keep your whatever ton car from contacting the road at all, right? It actually keeps them from interacting with one another. So it's lubricating and it's viscous, and it's actually made by this membrane right here. So let's introduce you to how you form a synovial joint. So we have what I said, but then how do you form this joint cavity, also called articular capsule or articular cavity? So I want you to imagine, visual for me, pull one of those really long soccer socks up over your knee, and it's snuggling this part, spanning that part, snuggling this part. That's what this is going to do. It's going to weave into the periosteum here and weave into the periosteum there, and then span the joint to sort of hold it together. What kind of tissue would you make the outside make of? It's dense irregular because it actually has to have strength from a couple of different directions. It's dense, but you knew it was going to be dense, right? Collagenous, right? And then, so that's the outer portion of the joint capsule. The inner portion is made of this purple tissue that you're seeing there. It's not a tissue that you learned before. It's called a synovial membrane, and it's a weird tissue. I won't show you a histology slide of it, but it's a connective tissue with secretory capacity. right? And it doesn't look like it'd be as connective tissue. I agree with you, but it is. Connective tissue is happening to line something and have secretory capacity. And what it does is it actually takes from the blood plasma all of the nutrients that it needs. It dumps them into this cavity. And the fluid is actually so rich in nutrients and oxygen that you don't need perichondrium around these two cartilages because it just sort of bathes them, right? And keeps them with proper amounts of nutrients and oxygen. Go ahead, Bridget.
Is this where, like, buildup of synovial fluid would be like rheumatoid arthritis?
It's directly related to the synovial cavity, but it's hold on to that question because it's the opposite of what you just said, but it's related to this cavity. Go ahead.
I was just curious about that diagram there. Do we have, it looks like the membrane like attaches to the hyaline cartilage. Is that
It's like
the case?
wherever the hyaline cartilage ends, the membrane covers. So sometimes there's a little bit of overlap, but it definitely covers any surface that's not covered by hyaline cartilage.
Okay,
And then it has a little overlap.
the hyaline cartilage is right against the synovial fluid.
Yeah, exactly. The hyaline cartilage is actually bathed in synovial fluid. Does that make sense? Okay, so these joints would be like right here, right, and here. All of your joints that are wiggly in your limbs are going to need to have this. Can you see the advantage? Because, of course, cartilage is really amitotic, hard to heal, right? You don't want friction of cartilage against cartilage. You don't want bone against bone because it will actually increase in size. So what you want is those two actually separated from one another and fluid in between them. So this is called a synovial joint. There's a whole bunch of types of synovial joint. I won't test you on the individual types, but I'll just show you a couple, okay? There's a whole bunch of different levels of mobility in a synovial joint. This one right here is called a ball and socket joint, and it has tons of movement in a bunch of different planes, right? Okay, but this one right here is a hinge joint, right? It really only has movement in this particular plane, kind of like the knee, right? And then you've got things that are like saddle joints that have like ability to slide and move around one another, but those are all synovial, right? Go ahead, what was your question?
So when there's no cartilage in between the bone and it's just friction, it gets bigger?
Yes, you will get bone spurs associated with that. And I'm about to teach you guys that when we do arthritis. We're going to do rheumatoid and also osteoarthritis in just a second, okay? Everybody good? All right, so what else is in the synovial joint? They don't show all of the things that are in it in this picture, so let's look at this picture. That is a knee that's actually torn a ligament, so you can see what else is in there. So this one's torn. Imagine that it wasn't torn. So what also is spanning the joint is ligaments, yeah? Okay, ligaments go within the joint cavity. They're not showing them in that picture, okay? And then, inside the joint cavity, you also might have some fat pads to help with cushioning, okay? And then, if it's the knee, in addition to the cartilage here and the cartilage here, I develop extra fibrocartilage menisci, lateral and medial menisci, only in some joints, not in all, right? Little extra fibrocartilage pad in addition to the other cartilage. And then the other way to stabilize the joint doesn't happen inside the joint capsule, it happens outside the joint capsule. So if I want to really stabilize a joint, strengthen the muscle that spans the joint on the outside. Because the muscle will stretch across and then the tendon will go down here. Muscle stretch across, tendon go down there. It's not happening in the joint, but it's stabilizing the joint, right? So if, for instance, you have bad back, except for extreme situations, do people say, don't use your back muscles? What do they say? Strengthen the muscles in your back, strengthen the muscles in your ab to help stabilize the joints, right? That's what you need to do, right? So good, intact, strong musculature around a weak joint will make the weak joint stronger, right? It doesn't do anything internally to the structure, it just makes it less likely that you are going to misalign the joint. Everybody okay with that? Okay, so we got ligaments. All right, so now we are ready to talk about arthritis. So arthritis is, the name tells you what it is. It's just itis, inflammation of joint, right? And we're used to thinking of arthritis primarily as the disease associated with aging and damage of a joint, but it's way broader than that. First off, there is acute or chronic arthritis. Do you guys know the terms acute and chronic, and how would you describe them?
Is like recent.
Yeah, and usually short term, like you can predict the life cycle of that particular disease, right? And chronic is going to be long lasting, could be forever, could be at least long period of time. So to give an example of acute versus chronic, let's just talk about STDs. Gonorrhea, it's acute. Go take the right antibiotics, you'll get over it, right? But if you've got herpes, you've got herpes. Yes, you do, right? And it's chronic, right? And it's going to be a thing that you just manage, right? And you're not going to get over it, okay? So there are a couple, although it sounds counterintuitive, there are a couple of acute arthritises. Because sometimes pathogens, meaning bacteria and viruses, like to invade joints. And when they do, they irritate the joint, so you get an arthritis, right? And so did you know that Lyme disease causes joint problems? Did you know that? Okay. And usually it does. Yeah, Lyme disease causes all kinds of problems. Among them, it irritates the hell out of your joints and your joints become relatively painful. That will be acute unless you allow for it to damage the cartilage, and then it will be a long-term issue. So if you can get it out of there before you damage the cartilage, then it will be an acute thing that you're going to get over. Now, we don't run into Lyme disease very much in Utah, but it's actually all over the country, right? And it can lead to all kinds of chronic problems, including this. And TB, tuberculosis, is if you didn't have enough freaking problems, if you got tuberculosis, it also infects your joints, right? And then rheumatic fever, which is caused by a specific manifestation of one of the strep bacteria, infects your joints quite often, especially in the later stages. It also is the one that infects your heart. It's how I got heart problems associated with rheumatic fever, right? So, and there are vaccines available for some of those, by the way, now. Not all of them. And then we get to the chronic arthritises, okay? So chronic arthritises, we're going to look at 3 different ones. So the first one is what people usually mean when they say arthritis, and that is osteoarthritis. And osteoarthritis is quite often associated with aging and wear and tear. So osteoarthritis, and there's also a genetic predisposition to it, but you don't inherit it. So for instance, if we were the same age, and we're definitely not, but if we were the same age, we would have different genetics, right? And if she had more collagen in her cartilage, she would be less likely to get osteoarthritis than me, right? Does that make sense? Okay, so osteoarthritis, what happens with osteoarthritis is one of 2 things. Either aging reduces circulation, which allows for more damage to the cartilage because of less synovial fluid present. Yes? Okay. And then the damage will allow for inflammation, which is the first reason they start to swell. And then as the cartilage degenerates, the bone will push against bone, and then you have bone spurs form. So this would be inflammatory in the early stages and actually bony tissue in the later stages, which further reduces mobility. Does that make sense? So that is osteoarthritis. Now, the other thing about osteoarthritis is that it is also a wear and tear arthritis. So you are also more likely to get it in the joints that are repeatedly used. So everyone could potentially get osteoarthritis as they age, but if you are a skier or a snowboarder, and you are, for instance, a competitive skier or snowboarder, meaning you do it a lot, where are you going to get arthritis? You're going to get arthritis in your knees. You are, right? If you are a pitcher, a baseball pitcher, where are you going to get it? Shoulder and probably elbow too. If you are Serena Williams, she is going to be a badass and have an amazing skeletal system and muscular system as she ages, but she is going to get arthritis in her wrist and probably her elbow. Yeah? It's wear and tear, right? You're just moving the joint so much that it actually breaks down the tissue in the joint. So just kind of expect that, wear and tear. Also, if you damage a joint, you are very likely to get arthritis in that joint. So that's what happened with this one. Look at that weird little gimpy finger right there. I carrying my husband's speakers around one too many times and dropped the damn speakers on my thing. So yeah, and it doesn't even straighten anymore. That's as much as it does, right? Where do people generally get it? Any place with repeated activity over and over and over again, but then also weight-bearing joints first, hips, knees. Women are far more likely to get arthritis in their hips than men's just because of sort of the architecture of our female hips, right? And knees, and then distal phalanges, right? Repetitive use joints is where you're probably going to get it. What do you do about it? Not a damn thing, really. Treat the inflammation so that it's more comfortable. Treat the pain, usually over-the-counter analgesic drugs, right, is all you do. If it gets really bad, you can do prescription versions of the same thing, like COX-2 inhibitors, like Vioxx, right? But really, there's no cure for it. Just happens. Okay, but then the next one is a far more serious situation, and that's called rheumatoid arthritis. So compare that to that. Okay, so rheumatoid arthritis is an autoimmune disorder. Autoimmune disorders are not associated with aging. A lot of times they hit 20s, 30s, 40s. And so what happens with any autoimmune disorder is your immune system is hypervigilant and makes a mistake. Your immune system forgets that the synovial membrane is not a pathogenic invader, and it starts to destroy the synovial membrane in your joints. It's an immune system, oops, is what it is. So what happens in this situation is it's a chronic inflammatory disorder. It's an autoimmune disease. There is no cure for any autoimmune disease at this point. There are things that can send them into remission, but I'm talking about an actual cure. There aren't any of those. So what happens is when you remove the synovial membrane, right, you remove the fluid. When you remove the fluid, you increase the friction. When you increase the friction, you get not only pain and damage, but also degeneration of cartilage. When you remove the cartilage, you get bone spurs that actually, right? And since you can't actually stop it, then it tends to be progressive. But autoimmune disorders are also a little unpredictable because what it could do is hit a couple joints and then go, hey, I'm going to leave that synovial joint alone for a while and go somewhere else or go into remission, and then it'll come back, right? And it might come back someplace different, right? So this is what it looks like. This is a more extreme case, right? Over time, what you get is basically you lose your synovial membrane permanently, and you get granulation tissue, which is basically scar tissue, instead of a synovial membrane, and then it's never going to reverse, right, after that occurs. So who gets this and where? So let's do where first. When people get rheumatoid arthritis, it is usually small joints first, and for whatever reason, we literally do not know. It's usually symmetrical in which it hits. If it hits the right wrist, it's going to hit the left wrist. If it hits your fingers, it's going to hit both, right? And we don't know why. But that's one of the ways that they can tell, oh, that might not be carpal tunnel syndrome. Let's see if we have antibodies that indicate rheumatoid arthritis, right? I mean, that's not the way they test for it, but it's one thing. It's like, it's not just that. So it's usually symmetrical. Mostly women get this disorder, not exclusively, but mostly, because women get most autoimmune disorders far more frequently than men do. Usually age 30, 40 can happen younger. There's even a juvenile rheumatoid arthritis that actually hits way, way younger. And we don't know why women get more autoimmune disorders than men do, but there is a really strong hypothesis that is being explored. It's kind of interesting, the hypothesis. First off, there is a genetic predisposition to autoimmune disorders. So, and think about it not as I inherit lupus, but I inherited a hypervigilant immune system, yes? That then could make a mistake after I have a viral infection, right? And it's going out looking for the viral antigens, and it's just like super duper activated, right? And it makes mistakes when it's super duper activated. So that's why you can see situations in which, for instance, in a single family, right, you can see lupus in one person and MS in another and rheumatoid arthritis in another, and all different manifestations of these autoimmune disorders. Because really, it's the immune system that's the problem. The manifestation is the symptom of your immune system being a problem. Does that make sense to you guys? So why? Why women predisposed to this? Because, of course, you can have in two families a bunch of boys and a bunch of girls. The girls are going to be more likely to get the autoimmune disorders. So here's genetics, and you can't do anything about that. And then there's this weird thing that seems to make women more likely to manifest. And we think, and there's a decent amount of support for this, but it's not probably the only explanation. So we used to think that pregnancy and childbirth did not allow for any communication between the maternal bloodstream and the fetal bloodstream. And that kind of makes sense because, of course, the fetus is half not you, right? And if your immune system saw the fetus, you would, of course, attack the fetus. So A couple of things happen in the woman to prevent that. First of all, it depresses your immune system when you're actually pregnant, right? So that you don't like launch an attack. And then second, I don't know if you guys know how the placentas works, and we'll talk about this in a lot of detail at the end of the semester, but let me just tell you. The placenta is actually the site in the wall of the uterus at implantation where the mother's bloodstream has a rich capillary bed, right? Backed up to the wall of the uterus. And then the fetus will develop a rich capillary supply that comes right next to but doesn't connect with the mother's bloodstream. It just snuggles up to it so that you can do osmosis or diffusion between them. Does that make sense? So the nutrients are moving between them and the wastes are moving between them. All is well and good during a pregnancy. But during childbirth, what happens is you have to yank those two capillary beds apart. Yes? And so childbirth is bloody. Yeah? It's bloody because you yank two capillary beds apart. We think that what is happening in those situations, and we do have indication, is that that is the time in which fetal cells can make it into the maternal bloodstream. Her immune system is relatively suppressed at that point, right? She doesn't have a response. She might not have a response for years. And then she gets a viral infection, right? Or a bacterial infection. And then her immune system becomes hypervigilant, going out and looking for anything that looks weird, right? Find one in your synovial membrane. Oh, rheumatoid arthritis. Find one in your myelin sheath, right? MS, right? Find one in a bunch of connective tissue, lupus, right? Right? Does that make sense? So this gives us a decent amount of strength. And by the way, we have found roving the cells of your progeny in a woman like 20 years after the birth. And they only found this like incidentally. I think it's kind of interesting. So they were looking at a woman's, they did DNA fingerprinting on a woman because they were looking for a genetic disorder, right? They were just doing DNA fingerprinting for a genetic disorder. And they got really confused because they found indications that she had Y chromosomes in some of her cells. And they looked and they're like, oh, you don't have a chromosome abnormality. Why the hell do you have some cells with Y chromosomes, right? And what they eventually found out was that those cells were actually her 22-year-old son's cells that were circulating in her system. And it wasn't that it was a son that was the problem. That's the reason that they found it, right? Because if it was an X chromosome, they wouldn't have noticed, right? But it was a Y chromosome. So that was the first place that they had documentation that, oh, those cells actually made it into the mom. And now they've been studying autoimmune diseases to see whether the predisposition in women is accounted for by the fact that women in their 30s and 40s, for instance, have quite often had a pregnancy. Not all the time, of course, right? And it doesn't account for all of them, right? But, and it seems to be that the high prevalence that accounts for like women have way more than men is accounted mostly for women who have had pregnancies that lasted into their third trimester. Meaning you don't have to have a live birth, right? But if you're in your third trimester, there's going to be a fully developed placenta, right? That is going to be pulled apart. So this is one of the big hypotheses, and the Catholic nun population volunteered to be a control group, as they quite often do. Because although some nuns, yeah, right, some nuns have had children because you are allowed to have had children, it's less common, of course, in the Catholic nun population than it is, right? Does that make sense to you guys? Okay, so good. So that is one of the things that is being studied really, really deeply to try to figure out why. Because they actually looked at hormonal environments, and it's not premenopausal versus postmenopausal women. It doesn't seem to have anything to do with estrogen versus testosterone levels, as far as we can tell. So that is rheumatoid arthritis. There is also a form of rheumatoid arthritis that, like I said, hits very young in children, and there is a really strong genetic predisposition with probably an environmental trigger to that one, and we don't know. Okay, and then the last arthritis is, it doesn't really seem chronic, but it's like repetitively acute, and it just keeps going, and it's called gout or gouty arthritis. Have you guys ever seen gout? So here is gout. Look at that arthritis. That does not look comfortable, does it, at all? Okay, and that's not a bunion. That's all inflammation that you're seeing there. So what happens with gout is certain people's metabolism will process proteins differently than others. So all of us need proteins in our diet. Yes, we can agree with that? But the byproduct of taking proteins into your diet is these nitrogenous wastes, especially high levels, like urea and uric acid and ammonia. Okay? Most of us clear those just fine with our liver and kidneys, and there's no problem. But some people, based on their metabolic predisposition, actually start to accumulate high levels of specifically uric acid. It doesn't get cleared very readily. When it gets in high concentration, it likes to crystallize in your connective tissues. So if you put crystals into this joint and then wiggle it, then it gets pissed like that, like that. See that? So this is gout or gouty arthritis. So the crystals cause the pain and inflammation. What happens is you'll get it in one location. It really reduces mobility. It's super duper painful. And then it'll go away and then it'll come back because it's your metabolism, right? Okay. So they used to call this the disease of kings because if you think back to the Middle Ages, who had access to the highest protein meals? Rich people, yeah, right? Everybody else lived on grains of some sort, right? Okay. And then of the sexes, which sex, historically speaking, yes, had access to the most high protein meals. So it was the disease of kings, and males were more likely to get it. And they still are more likely because, by the way, men still do, on average, eat a higher protein diet than women do. They tend to eat a higher protein diet than women do. So what can you do about this? You can try to suppress production of or increase secretion of the uric acid. You don't tend to get over it because it's your metabolic predisposition, but you can try to treat it. And sometimes they'll change your diet a little bit, but you can't go without proteins, right? But this person doesn't need to be on the Atkins diet, right? Which is super high protein, low carb, right? And medium levels, right? Right? So you don't want to be on that if you've got a predisposition to gout. Everybody good? Okay. So that is the end of that set of notes. And we will briefly start muscle. But we're not going to do anything hard today. We're just going to do something that will give you some confidence when you go into lab next week. Okay? Go ahead. Does somebody have a question? I feel like I didn't answer somebody's question. Did that happen? Okay. All right. So, oh, these are cool. Look at these cool, functional X-rays. I love them. It's the ankle. It's neato to see how the bones actually move. And the knee, and then the shoulder, which will lead us right into muscle. So we're going to talk about how muscles will actually wiggle your joints around. Okay, so let's give you an intro to muscle and tell you a couple things. Next week in lab is the hardest lab of the semester, okay? But it's okay because here's what you need to know about it, right? You're not going to absorb it all when you're in there, right? And it's fine, right? So you are going to have a whole bunch of muscles to learn. You're going to do the hardest ones first, not because we hate you, but because that actually gives you more time between that lab and your midterm. So what you're going to do is you're going to do 2 weeks on muscles. Next week will be appendicular muscles, which is these, right? Okay? And they're hard, and there's a lot of them. And then the week after, you're going to do axial muscles, which are way easier, and there are fewer of them, but you're also going to reinforce what you did, right, with appendicular muscles. And then you're going to have a study week in lab, and then you're going to have your lab practical. Good? Okay? So I want you to realize when you go into lab next week that you're going to feel overwhelmed, and it will diminish as time goes on. Let me ask you this. Is the skull any easier for you today than it was the first day that you saw it?
Yes.
Yes. The same thing will happen with muscle. It's a little slower to happen, though. It takes a little while because there's some functionality involved in it. And as we are going through, right, after you do your test, I am going to be teaching you all of the logic that makes it make sense, all of the mechanics that reduces memorization. So all I'm saying is please just do not give up the ship next week, and also don't miss lab next week because you're a freaking moron if you do, okay? And I mean that in the nicest way possible that I've ever called anyone a moron. So don't miss lab next week. And you have to come to lecture. Don't miss lecture next Thursday either after your test because I'm really going to help you to reinforce all of this and make the terms make sense. Okay? So what are you going to do in lecture versus lab? So what are you going to be tested on? And by the way, this test is a long way away, and it's long after you've already studied the muscles in lab, right? Okay, so I always do, when for the rest of the semester, if there's something really difficult in the material, I always put it at the beginning of the unit so that you have lots of time before you're tested on it. We'll do the same thing with the brain. We do the brain at the beginning, and you got lots of time to absorb the brain. So what are you going to be tested on in lecture eventually, not on your first test? So there's a little bit of chapter 9 because we just did articulations, but now we need to wiggle them, right? And then chapter 10 is really like the big organizing principles of muscle, like how they work and then how the physiology connects with the anatomy, right? Not heavy phys, because heavy muscle phys takes a whole class to do, but just enough phys to make it meaningful. And then chapter 11 is axial muscles and chapter 12 is appendicular muscles. So when you are eventually later given your test over muscles and other things, all of the stuff on lab is fair game on lecture tests, right? Same thing I did with bones. Within reason, right? Okay? So if you can't, on an image, after you have studied, name all of the superficial muscles of the quadriceps femoris group, because they're all visible right here on the quads, then you didn't study well enough, right? But all these little bastards right here, like they're hard enough to find when you actually have a specimen in front of you, and I probably will not ask them on an image. Does that make sense? Okay? So you have to trust me that I'm going to ask reasonable questions, and they are all going to be things that you study in lab, right? And to reinforce it, okay? In addition, as we go through this lecture material, I'm going to use all of the lab examples to reinforce it, right? When I teach you about an action, I'm going to teach you about an action of a muscle that you are learning in lab with the specific terminology that you are using in lab, right? And we're going to use them as examples. So it will reinforce each other. It'll just suck at first, but then later on you're going to feel freaking brilliant. You're like, I am the smartest person that I have ever been, and it will be true, right? Okay? All right, so what I want us to talk about today is I want to start talking about a little bit about the terminology and the basic mechanics of muscle, because if you can really understand the big picture of what they're doing, then there is way less memorization. So let's start on that for today. So let us start talking about just the basics of how muscles move. So we're moving from skeletal system to muscle, which is a really natural movement to make. And so what we said when we were talking about skeletal system was the skeletal system is used as leverage for body movement. Of course, the muscles are going to be the things that are responsible for body movement. So let's go back to that sort of idea that we said before. We said, okay, if I want to pull something out of the ground that is in the ground, I can have a rope that is attached to me and a rope that is attached to the thing, right? And I can use this stationary position as leverage to move that other position close to me. Yes? Okay. And that is what muscles do. So what muscles do is they use a stationary and a movable point of attachment. So let's start with an easy muscle, and we won't worry about the details yet, just one that you can visualize for me for a second. And we'll do this one a little bit later. So what a muscle has is at least one fixed or immovable point of attachment. We're going to call that the origin. When you contract the muscle, the origin should stay pretty still. Okay? It stays there. So that's like me standing right here and pulling something. Yeah? This is the origin. Okay? So the insertion is the movable point of attachment. Yes? And when you contract the muscle, here is what the insertion does. The insertion will move closer to the origin. Yes? Does that make sense? Does the logic make sense to you? So if we're talking about the deltoid muscle right here, right? I've got origin here, and it's actually two, but we'll just pretend it's one for just a second. Origin here, insertion there, and what the muscle does, the action is moving the insertion closer to the origin, right? So I want you to conceptualize for me for just a second. That means that if you truly and deeply understand the origin and the insertion, you can figure out the action. Yes? It also means that if you know the action, you can figure out which attachment is the origin and which attachment is the insertion. Does that make sense? Because if I switch them and I said, okay, this is the origin, this is the insertion, what I would be saying is some nonsense that basically means that when I contract that muscle, I pull my entire torso closer to my humerus, which doesn't make a damn bit of sense, right? Does that make sense to you guys, right? So the origin, the insertion, the action are all really intertwined, and if you truly understand them, it reduces the amount of memorization super dramatically. Okay, so that's what we're going to kind of work on today. We're not going to work on specifics. We're just going to work on sort of the idea of all of these. So there's a couple things you need to know about muscles. First off, muscles only pull, they never push, right? So I want you to think about me doing this, right? I'm pulling something out of the ground with my rope. Can I push the damn rope and move the thing? You cannot, right? So what muscles do is they only pull, they never push. And that means that If I want two opposite actions, let's look at these two actions right here around the same joint. I want this action and I want this action. What I'm going to have is a pair of muscles to do it, right? I'm going to have one that does this action. I'm going to have one on the opposite side of the joint that does the opposite action, right? Because this one can't push it back into position. That means that muscles tend to, and there are exceptions, but they tend to be arranged in opposing pairs, also called antagonistic pairs. Does that make sense to you? Okay, so the opposing or antagonistic pair says that the muscle that does this, whatever action I talk about first, we're going to call that the agonist, meaning the muscle that did the action I talked about. And then its pair is going to be the antagonist, yes? Okay, and then sometimes the agonist will have a helper. If the agonist has a helper, it's called a synergist. It's given it a little boost. So let's do some examples of agonist, antagonists, and synergists and talking about that whole opposing pair thing. So let's look at this action, okay, right here, and think about what you just clicked about origins, insertions, and actions for me for just a second. So let's do this action right here. What I want you to do is try to figure out for me, based on what you just learned, where approximately, you don't have to be specific, is the origin and where is the insertion? Where's the origin? Approximately, right? It has to be up here somewhere, right? Okay, and where's the insertion? Has to be down here somewhere, right? That makes sense to anybody to do this action. So you just verbalized something that so many people misunderstand, and that is you have to cross a joint to move a joint. I can't even tell you how many people tell me that this muscle that goes right here moves the wrist. It can't, right? The physics doesn't work. Does that make sense to you? So you have to cross a joint to move a joint. Okay, so now I want to do the opposite action, okay? And I want you to tell me where the muscle is and where you think the approximate location of the origin and the insertion is to do that action. Where's the muscle? It's going to be back here, yes. Where's the approximate origin? Up here, yes. And the approximate insertion, cross the joint to move the joint, down here. Does that make sense? Okay, good. Okay, so let's do some examples you're a little less familiar with, because that's the biceps and the triceps. And like you've been a human for a while, you know that, right? Okay, so that's all right. But let's do one you might not have worked out, yeah, ever in your whole damn life, okay? I mean, you have, but only like eating pizza. Let's do these muscles, okay? So this actually makes you really think about whether you understand the mechanics of it. So I'm going to do this action, which is closing my jaw, okay? Closing my jaw, not my lips. It's a different muscle. Closing my jaw. I want you to see if you can figure out where the muscle is that would do that, both origin and insertion. Where's the origin, do you think? Zygomatic arch. Where's the insertion? Mandible, right? Okay. Would it work if I flipped them? No, I'd be holding my mandible stationary and pulling my whole damn head down, right? So I want you to realize that laughing at those answers makes it less likely that you will write the damn things, right? You're like, that does not make a damn bit of sense, okay? So, right? So that's good, right? So that's the agonist, because that's the first action I talked about. This is the one that people have trouble with, and that is, okay, if that's the action I'm talking about, then this is the opposite action, right? Opening the jaw. Where is the muscle that does that? Where is it? Where's the origin? Where's the insertion? Remember, you only pull, you never push. Only pull. Good. She's got it. So it has to go, where's the origin? Where do you think?
Like here.
Origin. No, origin can't be there. Origin has to be down here. Yes? Got it? Origin has to be down here. Insertion has to be up there. Yes? That's not a muscle you actually learn. This one's the masseter, but this one's a neck strap muscle that you don't learn. But does it make sense to you guys? Can you figure it out? Just practice pulling things around. And then let me teach you a synergist. So a synergist is the helper for the agonist. And sometimes, so this muscle right here is called a masseter. And it closes the jaw, right? Or elevates the mandible. That's the other way to say it, elevates the mandible. It has a helper. And the helper isn't very strong, but adds some range of motion to it. And that is a muscle that starts way up here, called the temporalis, and goes all the way down here. And it's really thin, but it adds a range of motion to make it easier for me to pull from all the way down there, right? That's the helper, the synergist. Do the mechanics make sense that it would actually elevate the jaw? Okay, but when you see how thin it is, you'll see that it doesn't do most of the work. right? It just helps with the word. Does that make sense to you? Okay, so antagonist, agonist, and synergist. Now let's do some other actions. And you have some misconceptions about these. So let's try to get rid of them and think about what you said that you knew, which is that I know that I'm going to move my insertion closer to my origin when a muscle does its action. So I want to see if you guys can figure out with this action, where's the muscle, where's the approximate location of the origin and the insertion. Good? So this action I want to show you is this. So I'm going to do this. Okay. Where's the muscle? Where's the muscle? So not the second motion, this motion. Just think it through. Pull it around, see if it works. If you're pushing a rope, you're going to be frustrated. Pull a rope. So where is it? Where do you think? Do it on yourself and see what tightens. Yeah. So it is your abdominal muscles, right? But now tell me where's the origin and where's the insertion? Yes, the origin. So all the way down here in the pubic symphysis. And where's the insertion? Sternum and ribs. Yes? Yeah? And so what you do is, of course, you pull and feel it when you do it, right? Feel that muscle tighten, right? You pull the insertion closer to the origin. Got it? Okay. So you know how many people want it to be the other way around, right? They want this to be the origin and that to be the insertion. If that was true, this muscle, its primary job would be doing this. Which is really awkward for all of us, isn't it? No one enjoyed that at all, right? No. Glad it's not on video because it literally never happened. Okay, so now I want to know where I find the antagonist for the opposite action. Okay, I just did this. I'm stuck here until you guys figure this shit out. It's in my back. Where? Where's the origin?
Lower back. It's in your thigh.
No, it's not actually in my thighs. I do use my thighs to help, but they're not the actual one using it. Yeah, it's all the way down here on your sacrum and your iliac crest. And then the insertions are up here on my vertebra. Yeah? And those do the erector spinae muscles. How'd you know that? Nobody knows those muscles. Okay? The erector, does that make sense to you guys? Okay, let's do a couple more. And then I'll leave you guys alone. Well, one more. One more, and then I'll leave you alone. Okay, action. I'm looking at the hip action right here. Where's the muscle? Where's the origin? Where's the insertion?
Origin is in your hip.
Up here. Cross the joint to move the joint. The insertion has to be on the femur. Yeah, good. Okay, now show me its partner, the one that does the antagonist. The opposite action is what? Pulling it back. Where's the muscle? Yeah, it's the glutes, exactly. Where's the origin? Up here, right? And cross that joint to move the joint. So it has to be from the os cauci, right, to the femur. Yes? So when you understand those mechanics, then all you have to do is learn the specific part of the femur. Like the femur is not a mystery, right? Where is the origin and insertion of the deltoid? Well, I know that origins have to be up here in the clavicle and scapula. I'll learn the specific parts of the clavicle and scapula. And then I know that the insertion has to be on the humerus. I'll learn that that's the freaking deltoid tuberosity of the humerus, is where that thing attaches, right? And you won't flip origin insertion if you apply logic, right? Sort of, and it takes a while, right? You're too overwhelmed at first to apply logic, but later on you will be able to. Okay, I will see you guys on Tuesday for your test. Yes.